I'm Hannah Donnert with the Collaborative on Health and the Environment. Che enjoys bringing you the latest environmental health science through our partnership calls, webinars, science serves, publications, and social media. I would like to welcome everyone to today's Che webinar, which is titled Air Pollution and Pediatric Asthma. Our moderator today is Karen Wang, Director of the Collaborative on Health and the Environment. We will leave time following the presentation for a brief Q&A session. You may type in questions through the Q&A feature available on the menu bar at the top of your window at any point during the presentation. After the presentation, our moderator will read out questions for our speakers to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we've posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. This webinar is scheduled to last for 45 minutes and is being recorded for our call and webinar archive. With that, I'll turn things over to you, Karen.
Great, thank you so much, Hannah. Air pollution has been linked to the increased prevalence of pediatric asthma and reduced lung function growth in children. Children are more vulnerable to environmental contaminants, including air pollution. During today's webinar, Dr. Michael Brauer and Dr. Erika Garcia will give an overview of their recent studies, which both demonstrated strong associations between exposure to outdoor air contaminants and pediatric asthma in urban areas. Our first speaker is Dr. Michael Brauer. He is the professor in the School of Population and Public Health at the University of British Columbia and an affiliate professor at the Institute for Health Metrics and Evaluation, where he leads the Environmental Risk Factors team for the global burden of disease. Dr. Brauer has a doctorate of science in environmental health from the Harvard School of Public Health. His research focuses on linkages between the built environment and human health, with specific interest in air pollution and the global health impacts of air pollution. Our second speaker will be Dr. Erika Garcia. She is a postdoctoral scholar in the Department of Preventative Medicine in the Keck School of Medicine at the University of Southern California. She has a PhD from the University of California, Berkeley in environmental epidemiology, where she researched airborne occupational exposures in cancer in auto workers. Her main research interest is to examine the role of airborne environmental contaminants in the development of human disease. We're really excited today, and as Hannah said, if you have, we're going to save all the questions for the end of the webinar after both speakers have gone. So please type them in the Q&A box. And with that, I'll give it over to you, Michael.
Great, thank you. And it's a pleasure to be presenting to this webinar today. So I'm going to talk about some work that we've done on traffic-related air pollution and its relationship with pediatric asthma. This is work that has been led by Ploy Achakuglusut, who is a postdoctoral fellow at George Washington University. And it's a collaboration from a number of groups where we really were putting together available data sets to estimate the global impact of traffic-related air pollution as measured by nitrogen dioxide on pediatric asthma. This work was published recently in Lancet Planetary Health, and you can see the reference there on the bottom of the slide. So to motivate this work, even though it's been well understood that air pollution in general is associated with a whole range of adverse health outcomes, much of this work is focused on the average levels of air pollution, for example, that affect a city or region of a country or even regions of the world. Traffic-related air pollution is a relatively new understanding of additional impacts of air pollution that relate to variation in levels of air pollution across urban areas. Over the last 15 years or so, we've been able to develop high-resolution mapping capabilities, such as seen on this slide, to estimate exposure to traffic-related air pollution on a spatial resolution of hundreds of meters or so, or even less. And with these capabilities, we're also taking advantage of our understanding that depending on the pollutants, many pollutants that are emitted from tailpipes of vehicles will drop off at a very sharp gradient over 1 to 200 meters From high levels at roadside, over the course of several hundred meters, you'll get very sharp gradients in the levels of pollution. Nitrogen dioxide is one pollutant that's been used as a very common indicator of this form of air pollution that we call TRAP, or traffic-related air pollution. And some of the work that we've done in Canada, for example, would indicate that about 30% of the population in Canada and about 30% live within what we call a high traffic pollution zone. The same thing applies actually for the US. And about a third of primary schools in our major urban areas are located in this zone that we would call the high traffic zone, where individuals in these areas would be influenced by the emissions from traffic and vehicle exhaust. There have also been a number of epidemiologic studies conducted around the world, especially in North America, Europe, and Japan, that have taken advantage of this capability to map air pollution at high spatial resolution and linked it to a number of health outcomes. And in particular, what I'm going to talk to you about today is pediatric asthma. So this is a result of recent meta-analysis summarizing a number of these studies. And overall, there was an association, a relatively consistent association, seen an increase in new onset. So this is incident pediatric asthma associated with increased exposure to traffic-related air pollution. So with that background information, together with colleagues, we conducted a first set of global estimates where we were looking not just at nitrogen dioxide and traffic-related air pollution, but at particulate matter and ozone, different forms of air pollution, and their relationship with asthma incidence as well as emergency room visits for asthma, in order to estimate quantitatively what the global disease burden might be from these different pollutants on this outcome of asthma. In this first analysis that was published last year, we demonstrated some large impacts, but also uncovered many uncertainties and a need for methodologic refinements in the work. For asthma incidence, which is arguably a much more important impact on health than exacerbation of existing asthma, the strongest evidence that we found was for associations with traffic-related nitrogen dioxide and for children. The methods that we employed in this paper, however, were unable to really capture that fine scale variation that we see close to major roads. So with that background, we embarked on a new study, which is what I'm going to focus on today. Now, to estimate the burden of disease attributable to air pollution or any risk factor, there's several different pieces of information or pieces of data that we need. One is the level of exposure. In this case, where we're estimating throughout the entire world, we're really trying to estimate the exposure throughout the whole world at this fine spatial resolution. We also need to understand the concentration or the exposure response relationship. What is the magnitude of impact on a particular health outcome related to a particular level of exposure? And then the level of exposure that we see in various locations are compared to an optimal level, a level that we would say is a level at which we would observe no adverse impacts, for example. With those three sources of information, we can calculate what's called a population attributable fraction. That would be the fraction of that particular disease that we can attribute to that exposure. And then we combine that fraction with estimates of the amount of disease that occurs in different locations over different pieces of time. Putting those two pieces of information together, the disease-specific burden and the population attributable fraction, we calculate the attributable disease burden, which is the amount of disease that we can say is attributable to that particular exposure or risk factor. So first of all, looking at exposure, we took advantage of work that was led by Andrew Larkin and Perry Heistad at Oregon State University. This is published in 2017, which is a global model of high resolution estimates of nitrogen dioxide concentrations. This took advantage of satellite-derived estimates of nitrogen dioxide as well as land use information, for example, road proximity, land cover, and a number of other sources of information. These were related to more than 5,000 available ground measurements of nitrogen dioxide in a regression model, and then that regression model was applied continuously throughout the globe to produce these estimates. You can see, for example, the resolution where you can actually differentiate levels within different cities in these examples. So we took that information, and that information you see in the middle panel directly from those estimates was regridded and reprojected to match population data that's also available at high spatial resolution. In this case, the GHS POP database from the European Environment Center, which provides population and age-specific populations at 250-meter resolution throughout the world. So with that information in mind, we can start to actually do these calculations of the burden of pediatric asthma related to this exposure. For the effect size, we looked at a number of published meta-analyses, and the one that I showed you earlier in the slide, the most recent meta-analysis conducted by Haneen Kreis and colleagues, utilized over 40 studies conducted in North America, Latin America, Europe, and East Asia, and showed an increased risk of pediatric asthma related to nitrogen dioxide exposure. You can see the other meta-analyses also indicated increased risk, so there's relative consistency in the literature, and we selected the most recent one of these published meta-analyses. I'd also like to point out that assessments that have been done for the health impacts of nitrogen dioxide air pollution by the US EPA and Health Canada recently both indicated that there's likely a causal relationship between long-term nitrogen dioxide exposure and pediatric asthma development. So we now have the population information, we have the relative risk information, we have the exposure information, and the last piece of information that we need to conduct these estimates are the national incidence rates of pediatric asthma. So how much asthma actually occurs in different parts of the world for different age groups. And for that, we took advantage of information from the Institute for Health Metrics and Evaluation and the Global Burden of Disease Project, which produced these estimates for every country in the world and actually spanning over time. For the optimal level or the counterfactual level, we looked at 3 different concentrations, both a concentration of 0, a concentration of 5 parts per billion, and selected for our prime analysis 2 parts per billion, which is the lowest level that had been observed in the epidemiologic studies covered in the meta-analysis. So moving on to results, we see that the estimates indicate that 4 million children developed asthma in the year 2015, which is our year of analysis, due to exposure to nitrogen dioxide air pollution. The largest burdens, as you would expect, occur in some of the largest countries in terms of populations in the world. More than 750,000 cases in China, 350,000 cases in India, nearly 250,000 cases in the United States, for example. If we look at the rates, so now we're adjusting by population level, you see an interesting pattern that is quite different than other air pollutants, that actually the highest rates occur primarily in high-income countries, so in countries in the Persian Gulf, as well as Canada and Taiwan. And this is a combination of both the high incidence, the high baseline incidence of pediatric asthma in these countries, as well as relatively high levels of traffic-related air pollution, which contrasts something with levels, for example, of particulate matter, where we see the highest rates in low-income countries, for example, in South Asia. More than 95% of the children that were affected and more than 90% of the asthma incidents occurred in areas where the levels of nitrogen dioxide were actually below the current World Health Organization guideline, which is 21 parts per billion. And as you recall, our optimal level in this analysis, so the lowest level at which health impacts have been observed, was 2 parts per billion. So actually there's quite a lot of evidence of health impacts below the current World Health Organization guideline. Overall, our estimates suggest that 13% of global pediatric asthma burden is attributable to this exposure. This is quite a substantial proportion of the asthma that children are experiencing in the world. As I mentioned before, this nitrogen dioxide attributable asthma incidence impacts are largest not in the low-income countries, but actually in middle and high-income countries, and especially in the urban areas of those countries. This reflects both the concentrations of traffic-related air pollution, as you can imagine, the highest levels do occur in urban centers, as well as the fact that more children, a higher proportion of children, live in urban areas compared to rural areas, especially in middle and high-income countries. We looked also at a database of cities, and we found that in cities, for example, the proportion of pediatric asthma incidents that we could attribute to traffic-related air pollution could be as high, nearly as high as 50%, for example, what we observed in Shanghai. And it exceeded 20% in 90 of the 125 major cities that we were able to evaluate. And it was highest in cities in China, as well as in Moscow and in Seoul, Korea. So just to wrap up, through this analysis, we've estimated that traffic-related air pollution is responsible for a very sizable proportion, 13% globally and more than 20% in many large cities, of the pediatric asthma that is observed globally in the world. This accounts for 730,000 disability-adjusted life years lost in 2015. Importantly, while only 3% of the children were exposed above the World Health Organization guideline, 4 million new pediatric asthma cases in 2015 were attributable to this form of air pollution. This work suggests that reductions in traffic emissions and or other mechanisms to reduce exposure to traffic-related air pollution could prevent a large portion of pediatric asthma, especially in urban areas. So with that, I will thank you for your attention and turn you over to Erika for the next presentation.
Great, thank you so much, Dr. Brauer. We're just gonna let Erika pull up her slides here now and get ready for her presentation.
Okay. So thank you very much for inviting me here today to talk about our recent work. And thank you, Michael, for your introduction on the topic as well. So I'm going to be talking about a recently published study entitled Association of Changes in Air Quality with Incident Asthma in Children in California. And this is from 1993 through 2014. And I just want to, from the outset here, acknowledge my co-authors listed below on this work. Okay, so Michael alluded a little bit to this, that air pollution is a well-established risk factor for the exacerbation of pre-existing asthma, but what's less certain is whether air pollution plays a role in the development of asthma incidence in children. So it's likely causal, but we would like to tighten the certainty around that. And so our objective here was to examine whether decreasing regional air pollutants were associated with reductions in the incidence of childhood asthma. So we know in Southern California, air pollution levels have been declining over the last several decades, and we wanted to see, was there a corresponding decline in the rate of asthma incidence in children during this time? And this work was recently published about 2 months ago in the Journal of the American Medical Association. So I'm going to step back a little bit here and talk about the usual air pollution analysis done for an outcome, like a chronic outcome like asthma. So here is just a little cartoon depiction of the state of California in the United States. And there's 9 little circles around here indicating some locations that are being recruited for the study. So we'll recruit over some geographic space, and then we assess the exposure. And this is just a cartoon depiction of some variation of exposure. So it's not actually what air pollution looks like in California. It's just a little depiction here. So high exposures is darker red, and it gets a little bit lower as you go towards the yellow and the white. So you assess exposure in these different communities. You follow for the outcome. That's just indicated by the coloration in the dots. So lighter is less incidence of the outcome. Darker would be more incidence of the outcome. And at the end, what you do is you compare the rates of the outcome by the exposure level. So the rates of asthma incidence in high versus low air pollution communities. But we know that air pollution is going to be intrinsically tied to geographical space. And so what we're concerned about is unmeasured spatial confounders. So if you're unfamiliar, a confounding variable is a variable or a factor that's associated with the exposure, such as air pollution, and it's also causally related to the outcome, like asthma incidence, and this would cause a spurious or artificial statistical association between these two factors. So one example would be access to green space. We know in communities with high levels of air pollution, they tend to have lower number of parks and other green space to recreate. So children may not go outside and be physically active. There may be higher, this would lead to higher obesity rates in the children. And we know that obesity is a risk factor for asthma. So that pathway between air pollution and incident asthma that goes to this green space may make it look like air pollution and asthma are associated when they are truly not. It's just because of this confounding factor, this access to green space. And because air pollution is tied to geographical space, we're concerned about these spatial confounders and that are unmeasured because it's hard to measure everything that we're concerned about. So what if instead we still recruited over the same geographical space? We still got those 9 little circles throughout the state of California, but now at different times. So here we have children that were recruited in 2000. Children again were recruited from these same locations in 2005. And last, they were recruited again in 2010. So these are different sets of children. They're all 4th graders, but they're recruited at these different points in time from the same communities. And during this time, air pollution levels are changing. Again, just a little cartoon depicting changing air pollution over time. It doesn't look like this, but you can see it kind of got lower as you went a little bit later in time. So 2010 levels are a lot lower in comparison then to the 2000 levels. And so the same thing, you follow for the outcome. And at the end, you compare within the same geographical space. So rather than comparing between locations, you're comparing the location to itself, but at different points in time. So this little circle down here is kind of in Los Angeles. So we would be comparing children in Los Angeles to other children in Los Angeles, but when air pollution levels were a little lower. And again, when they were more further reduced. And the nice thing about this design is that we control for these unmeasured spatial confounders because people who live in the same community will be more similar to each other. So again, comparing within a community to itself, but over time. So again, just a particularly nice aspect of this design is that we are controlling for these unmeasured community level or spatial confounders, which can be very difficult in air pollution epidemiology. We're also taking advantage of a natural experiment because we have during the same time frame reductions in air pollution levels. And this also allows us to quantify the health benefits of those reductions in air pollution. So oftentimes we're saying higher air pollution leads to higher health, negative health outcome, where here we're saying we know the air pollution went down. What happened to our asthma incidence rate in children during the same time? And this study design has been previously used by researchers at USC for different health outcomes, including lung function growth and bronchitic symptoms in children. Okay, so some specifics about what we did. We used data from the Southern California Children's Health Study, and this is a long-term study of cardiopulmonary health outcomes in children. It began in 1993. There were 12 communities that were recruited from the Southern California region, and they were selected to represent the different mixture of air pollution in Southern California. And this is a little map depicting the area. So this is Los Angeles County here, and these are the different communities that were selected as part of the Southern California Children's Health Study. So the air pollutants that we examined were 4 key pollutants. All of these have federal regulatory standards, and they're known to have health effects. These were nitrogen dioxide, which is the pollutant that Michael talked about, ozone, particulate matter less than 2.5 microns or PM2.5, and particulate matter less than 10 microns or PM10. So we look at those 4. And what we were specifically aiming for, which is a little bit in contrast to the previous presentation, is those background regional level of these pollutants. So what people will be generally exposed to in a community. We know that sources like traffic, so you can see that freeway here, is going to lead to smaller scale variation in air pollution exposure. So we know the communities that are lying very close to the freeway are going to have higher levels of air, of traffic-related air pollution compared to communities a little further away. And you saw those in those really nice maps that Michael presented. We actually want to not look at that. We want to control for it. And in our analysis, we actually did control for local residential exposure to traffic pollutants. So we're getting background level. That's what we're after. So some more specifics about what we did. We used data from 3 cohorts in the CHS. So this totaled a little bit more than 4,000 children. We restricted to participants in the same 9 communities. So 9 communities at these 3 different points in time. Again, because we want to make the contrast within community over time. So all of the children were followed for about 8 years, for about 4th grade to high school graduation. You can see the years here. So the first cohort was in 1993 through 2001. The second cohort in 1996 through 2004. And the last, the most recent cohort was in 2006 through 2014. And all of these children were free of asthma at the start of the study, at the start of follow-up. And they were prospectively, so forward in time, assessed for doctor-diagnosed asthma via a questionnaire. And during the study period, we identified 525 new cases of asthma. So they were diagnosed newly during the follow-up period. And for those keen on the statistics, just a little detail here. So we did use multi-level Poisson models, which are appropriate for our analysis here. We included a random effect for cohort nested with town, and then also a fixed effect for town. And again, this is important because we're trying to make the comparison of within a community, so within the same community, but at different points in time when we know air pollution levels are changing. We adjusted for a variety of potential confounders that were identified a priori, and those are listed here. Our exposure of interest is community level annual average pollutant concentration in the baseline year for each cohort. So that first year in each of the 3 cohorts. So these are 1993, 1996, and 2006. So everyone in the same community, in the same cohort, would have the same exposure level. And the outcome is going to be the asthma incidence during follow-up. So here's a graph depicting ambient NO2 levels during our follow-up period. So you can see the nitrogen dioxide levels are here, and then the time from 1993 to 2011. And each of these lines represents data from one of our communities, so one of 9 communities included here. And you can see that overall there was a nice downward trend over time in the NO2 concentration. The 3 rectangular columns here just indicate the baseline year for each of the 3 cohorts in 1993, 1996, and 2006. And the red line going across here is the United States National Ambient Air Quality Standard, the NAAQS, for the specific pollutant. So for NO2, the NAAQS is 53 ppb, and you can see that all of our communities were well below the NO2 NAAQS. Not quite so much for the WHO standard, which was 21, which would be here. You can see a nice decline. And over this period from 1993 to 2006, there was a nice substantial change in NO2, so a reduction on a median change or average reduction of 4.3 ppb in a community. This is about a 22% reduction in NO2 levels. Here's the same plot, but for ozone. You can see a little bit of a decline at the beginning, but not so much in later years. Most communities are well below the ozone NAAQS, and the change from 1993 to 2006 was about 15%, or 8.9 ppb. Plots for PM 2.5. For PM 2.5, we saw a nice decline over this period. Some communities are still above the standard. This actually changed in 2012, so it's the current standard. Before that, it was 15 micrograms per cubic meter. And you can see there was a fairly large decline in PM 2.5 between these 2 years within the community. So this was a 36% reduction at PM 2.5 levels, so an 8.1 microgram per cubic meter decline during this period. And lastly, PM 10, not as large of a decline. You have a little bit more in later years, but not with the 3 time points that we're looking at here. So it's about a 9% decline for 4 micrograms per cubic meter. but we're still, able to take advantage of this natural experiment. So our findings here, so these are all scaled to that average reduction seen in the 4 pollutants. So those are just noted here on the bottom again for you. So these are reductions. So you would expect if there was a relationship between the incidence of asthma and the air pollutants going down, this number would be below 1 because it's a reduction, so it should be lower. The first model here that I'm going to present is for all the adjustment factors listed in the earlier slide, and then except for residential traffic, and the second model is going to be for residential traffic. And the reason why these are separated is because we had some missing data on some of our subjects. You can see that in the different N, and this is kind of just to separate those analyses so you can see. Okay, so we found that reductions in nitrogen dioxide was associated with lower asthma incidence rates. And for a 4.3 ppb reduction in NO2, this was associated with 20% lower rate of asthma. You can see when we adjust for residential traffic, it doesn't markedly change that result. Now, reductions in ozone were also associated with a lower asthma incidence rate, but because these confidence intervals include the null value of 1, you can see that by the line crossing 1, these results were not statistically significant. For PM2.5, also reductions in PM2.5 were associated with lower asthma risk. So for a 8.1 microgram per cubic meter reduction in PM2.5, there was an associated 19% lower rate of asthma in children. You can see the confidence intervals are a little bit wider here, a little bit more uncertainty, both in the numeric and you can see in the visual depiction of the confidence intervals. And the results for PM2.5, while in the direction we would expect, were null. So overall, adjusting for residential traffic didn't markedly change any of the effect estimates. And this is just a figure here showing the crude asthma incidence rate on this axis, and then nitrogen dioxide concentration. So it goes lower as you go from left to right. Each of the colors represent one community, and there's 3 dots for each of those because there's 3 points in time. They represent the 3 different cohorts, with the smallest dot being the earliest cohort and the largest dot being the most recent cohort. And the regression lines just for those 3 points. And you can see overall, as nitrogen dioxide concentrations went down, so as you move from left to right, the asthma incidence rate also declined, with those that experienced the largest decline in nitrogen dioxide concentration also experiencing the largest declines in asthma incidence rate, like the city of Long, or the community of Long Beach here, where you can see. And overall, fairly consistent. But not all of them. You can see Riverside kind of goes the other direction. For PM2.5, similar trend, though not as consistent as for NO2. And this is again reflected in those uncertainty in the 95% confidence interval. We also assessed whether the effect estimates differed by different factors, and we found that there was no differences by the level of air pollution, so whether you were a high or a low air pollution community, whether it was boys or girls, by race, ethnicity, parental educational attainment, or the use of Spanish versus English language baseline questionnaires. And this is to get at acculturation because a lot of our students were Hispanic. So all of these effect estimates were not different by these factors. Additionally, the findings for NO2 were robust to a large number of sensitivity analyses. For PM2.5, the effect estimates often stay the same, but the confidence intervals would be wider and often were null. So just to summarize here, first is that there were great reductions in air pollutant concentrations between 1993 and 2006 in this region. We saw for NO2, this was a reduction of 22%, and for PM2.5, this was a reduction of 36%. So that's great to see that. And we also saw that cleaner air was related to lower rates of new onset or incident asthma in children. For a reduction of the 4.3 ppb NO2, this was associated with 20% lower rate of asthma. And for that average reduction of 8.1 micrograms per cubic meter of PM2.5, this was associated with a 19% lower rate of asthma. Again, these NO2 findings were robust in a variety of sensitivity analyses, and there was no evidence that the findings were driven by a specific subgroup of children. Some just last concluding remarks here is that this study provides further evidence for a causal link between ambient NO2 exposure and the incidence of childhood asthma, and that these effects were observed in communities that were well below the current EPA, the US EPA standard of 53 ppb. The mean baseline, so that 1993 baseline NO2 concentration, the average among all those communities were only 24 ppb. So this may have some implications for the current NO2 regulatory standards in the US. And thank you very much for having me again. Again, just acknowledging my co-authors, our funding, and of course the students and their families and the schools for participating in these studies. Thank you.
Thank you so much. Okay, now we're going to move on to our Q&A period. So if you guys have any questions, please type them into the Q&A box. Michael, we'll start out with a question for you. Are you there, Michael?
Yes.
Okay, great. In low-income and middle-income countries, due to perhaps lower healthcare access, could underdiagnosis of asthma be contributing to some of the results you presented for the incidence rates in middle-income and high-income countries?
Thanks. So yeah, it's a good question. And we do in those estimates of asthma burden try and account for differences like that. But that certainly is a possibility just because of lack of high quality data in many of those settings. But I do think it's important to point out that asthma generally tends to be a disease of development. So we see certainly over time that even in high income countries, rates of asthma have increased over time. And there is a general tendency for asthma rates to be highest in high income countries. There's many people have probably heard of the hygiene hypothesis. That's sort of been refined over time, but things like increased antibiotic use, C-section deliveries, highly hygienic indoor environments are all things that have been related to increased incidence of asthma. And those things tend to be more common in high income countries. So while underdiagnosis may be a part of that, it's probably more closely associated with lifestyle factors that are associated with higher income living.
Okay, great. And then this is another from an audience member combined with the question that I had. Have you used the results of your study to do some rough calculations for decreases in pediatric asthma in different policy or intervention scenarios that would decrease NO2? Specifically, an audience member asked about switching to electric cars or green space buffers around highways.
So no, we haven't done those kinds of analyses yet, but that is the kind of work that has been underway for other forms of air pollution, for particulate matter, for example, and the data are available to do those kinds of analyses. Specifically, the questions about electric vehicles or green spaces. So obviously the electric vehicles would have no emissions of nitrogen dioxide. So depending on the penetration, what percentage of the fleet was electrified, that could have impacts on asthma. And on the sort of greenness or vegetation, the literature on that, I would say, very mixed. And in general, there's lab studies that sort of support that vegetation can reduce levels of pollution, but in most real world settings, that does not seem to be the case, and probably relates to wind speed and wind conditions. So in the laboratory studies, under very, very low wind conditions, vegetation can absorb some amounts of pollution, but in real world settings, it doesn't appear to be very effective.
Okay, great. Another attendee asked, I live in Northern Virginia and my school system continues to site new schools on heavily traveled roadways. I don't know how close they are, probably within 200 yards, but how would you recommend parents go about getting the air tested for these pollutants? I know the American Lung Association does tests for the entire community, but I have to believe that pollutant levels would be very high in these specific locations.
Yeah, so in general, actually, we don't recommend that people go about doing testing for air pollution, but if that really is necessary to get action. And the reason that I say that is because it becomes very expensive, and you get into all kinds of situations of where to site measurements, how long to make measurements, how to conduct the measurements. And really, we know quite well that if there's a certain level of traffic and a certain level of distance from a road, that you're going to have high levels of these traffic related air pollutants. So I would actually first ask about the level of traffic, especially the level of traffic that may be stop and go traffic. And there's quite a number of guidelines out there. And in fact, even in the state of California, there's a Senate bill requiring mitigation for schools that are located within a certain distance of roads that have a certain level of traffic. So there's a number of resources that I would go to just to look at the level of traffic and the distance. But if measurements are really necessary for action, then probably the first place to go would be the county health department. And they may be able to leverage resources, usually from the states that are actually doing local air quality monitoring. But the air quality monitoring in the U.S. is really done at the state and local level, and it differs quite a lot from location to location in terms of what resources they may have in order to do that kind of monitoring.
Thanks. Erika, we have a question for you. Well, first, could you kind of give a background about why were there such large decreases in NO2 and PM 2.5 in California over this time period? And then a follow-up question to that is, you know, attendee asked California reduced their C-section rates over this time period as well. Was there any comparison of C-section rates across those time periods?
Yeah, so for the first question about why air pollution levels have been going down, so it's also kind of interesting. So we use the phrase natural experiment when we're talking about these nice reductions in air pollution. It wasn't natural, right? It was human intervention. We purposefully made policies and regulations to reduce air pollution levels in the Southern California area. So LA is notorious for its air pollution, and there have been a large number of regulatory actions and policies that have been aimed specifically to reduce air pollution from vehicle traffic, from the ports. So we have two very large ports here in LA, of Los Angeles and the Port of Long Beach. There's diesel truck traffic, there's large freeways, and so there have been multiple regulatory efforts around these sources, as well as other stationary sources of air pollution exposure over several decades in this area, which have led to this great achievement of reducing air pollution levels. So multifactorial. Regarding the second question about C-section, so we don't have data on that in this analysis, but we were generally concerned with things that did vary over time. So I talked a little bit about spatial variation, so things that vary within a community over space, but the other thing that this analysis does bring up is temporal confoundment. So things that vary over time that may vary similarly to air pollution exposure and may confound the relationship between our exposure and our outcome. So while we don't specifically have information about C-section rates in our children, what we did do to try to get at this is one of the sensitivity analysis, we actually control for time. So we control for the fact that these are 3 different cohorts at 3 different points of time, and that can ideally get at the overall trend of what's happening over time. But because we are looking at the specific reductions in air pollution levels within a community, we can still detect an association. And for NO2, these results were robust. So we still saw a very similar effect estimate, and it was still statistically significant even after controlling for time in a couple different ways.
Great. We have another question for you, Erika. Did the sensitivity analyses you performed address co-pollutant effects, such as were multi-pollutant models conducted with both NO2 and PM 2.5 to determine whether the NO2 associations were sensitive to PM 2.5 levels and vice versa?
Yeah, so this is often an interesting question for air pollution health studies, because we know we're exposed to a mixture, but oftentimes these mixtures kind of go up and down together. So as NO2 levels go up, so do PM 2.5 levels, and that leads to these pollutants being highly correlated, specifically NO2 and PM 2.5. So we were not able to look at them in a model together, a 2-pollutant model. The only pollutants that we were able to examine together were ozone and the 3 other pollutants. And this is because ozone was had a sufficiently low enough correlation with the other 3 pollutants. And so models for NO2 that adjusted for ozone still remain robust. I don't remember off the top of my head the PM 2.5 results, but we were not able to include a 2 pollutant model with both NO2 and PM 2.5 because of this multicollinearity issue.
Okay, great. Michael, we had one last question for you. During your study, did you consider prenatal exposure to NO2 and this effect on pediatric asthma incidence rates?
Sorry, can you just repeat the question?
During your study, did you consider prenatal exposure to NO2 and this effect on pediatric asthma incidence rates?
Yeah, the analysis that we did is really we're not differentiating between at the time of exposure. So we're taking those took those studies from the literature that that looked at actually different exposure windows, whether that was during infancy. Some of those were also looked at exposure during the prenatal period as well. So it's actually a mix of studies. In general, the literature suggests that both prenatal exposure and exposure during the very, very early infancy, within the first 6 months to 1 year, are associated with pediatric asthma. We didn't differentiate between those.
Okay, and then this is one last question. I'm not sure who could answer this, but do either of you guys, can you explain the mechanism for how these pollutants cause asthma?
Michael, do you have anything to say specifically on that?
So very generally, it's still an evolving area in terms of the causes of asthma specifically. There is some suggestion that nitrogen dioxide can increase lung permeability. So it's a pollutant that's moderately reactive, meaning that it will travel actually down throughout the entire airways, but still, because it has reactivity, it can affect tissues throughout the airways. And so and it's been demonstrated in the lab that it can affect permeability, which means other agents, as well as other cellular agents that your body is producing, for example, in response to other inhaled factors, would have more access to different tissues of the lungs and could affect development of asthma. But that's about all we can say about that. So it's really still an open area.
Okay, great. I think that's all the time we have for questions. So thank you, both of you, for your wonderful presentations today. Back to you, Hannah.
Great. Thank you, Karen. We're approaching the end of our webinar today. A video recording will be available on CHE's webinar webpage soon, and tomorrow you will receive an email containing a link to the video. If you are new to CHE and would like to stay updated about upcoming events or more, please sign up to receive a newsletter by selecting the Join Us tab at the top of any page on our website. Our website is healthandenvironment.org. Additionally, if you appreciate these CHE webinars, bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers, Dr. Brauer and Dr. Garcia, for taking the time to present today, and to you, Karen, for your excellent moderation. Thank you so much for joining us, and have a great day.